Hello, everybody, and welcome to an edition of Tales from the Heart that's a little bit new to our repertoire. We, as you know, have been speaking to some authors of some books, but we're also going to be speaking this year more frequently with authors of publications that are of interest to the HCMA and to the cardiac community. So today, this is the first one of 2026 where I have evaluated a bunch of articles and I've asked that we be joined in podcast to discuss this article that was just published on January 7th. And the senior author here is Dr. Sharlene Day. So, Dr. Day, you are not a stranger to Tales from the Heart. So, why don't you just let everybody know where you're from and we'll get into this paper in just a little bit.
Sure. Well, thank you so much for inviting us, Lisa, for highlighting our paper. So I'm Sharlene Day. As Lisa said, I am a professor of cardiovascular medicine at the University of Pennsylvania. And I have been taking care of patients with HCM for about 20 years now. It actually was 2006 when I started our Center of Excellence at the University of Michigan. And then I moved to the University of Pennsylvania in 2019, and I'm now a member of our Center for Inherited Heart Disease here at Penn. So I see patients with HCM and also do research that sort of spans from molecules to people. So that's who I am.
Fantastic. And you have a younger member of your team here, and I'm going to do my best. Everybody knows me and names are not always great friends. Neha. Mm-hmm. I did the first name right. We've got that. Hafeez.
No. Hafeez, very close.
Hafeez. I was close. So why don't you tell us a little bit about your background and where you came from, and then we're going to dive into your article where you are the first author.
Sure. Thank you so much for this opportunity, Lisa, and for inviting us to be on this podcast. So I'm currently a third-year internal medicine resident at the University of Pennsylvania, where I've been able to work with Dr. Day both in a clinical and a research capacity. I'm very grateful for that. I actually met her for the first time when I was an undergrad at the University of Michigan, where I studied hypertrophic cardiomyopathy from a more molecular standpoint. Was very lucky to study genomics and cardiovascular disease while in medical school, and then now I'm studying HCM from a more clinical perspective, looking at social determinants of health, and that's what our paper is on.
So for our listeners who are not familiar with the terminology, what are social determinants of health?
Yeah, it's a great question. So social determinants of health are all of the non-medical aspects that affect your healthcare. So it's many different things that range from your income to where you live, access to healthy groceries, access to healthy exercise, et cetera, which you can imagine would all affect your ability to stay healthy. Not being able to get fresh groceries means that you wouldn't be able to have certain vitamins and certain aspects of your health that are taken care of from a dietary perspective, and that leads to overall health consequences as well. So these are the things that we were looking into that we may not necessarily think about classically as affecting our health, but we know do.
So for those of us who've been around the block a few times with HCM, we know this by virtue of the work that we've been doing. When we meet somebody who doesn't have access to healthy food, who has to travel a long way to get to a physician, who doesn't have the finances to pay for a center of excellence level care if it's not in their network. We know all of these factors can have negative consequences on outcomes. And you've done some really interesting work here on this paper, which is why it rang all of my spidey senses that this is something important the community needs to understand better. So why don't you talk to us a little bit about the objective, and then we'll talk a little bit about the design of this study and what we found.
Sure. Yeah, like you mentioned, there are differences in the care that patients can receive simply from where they live and what access they have to healthcare. And that's been studied quite a bit in acquired cardiovascular diseases, but we haven't really seen that much research on how social determinants affect more genetic mediated diseases like hypertrophic cardiomyopathy. Do they affect disease outcomes in the same way? Not sure. And that's what we wanted to look at through this paper. So we used the SHARE registry, the Sarcomere Human Cardiomyopathy Registry, which is an international registry that Dr. Day has done a lot of work with, that contains both clinical and genetic information of patients with HCM. We're able to correlate their zip codes with their clinical and genetic outcomes to get a sense of how where they live affects their clinical outcomes.
So when we're talking about zip codes, that then gets us into, when you're talking about social determinants of health, it gets us into red line districts and red line areas. Can you tell some of our listeners what a red lined area is if they're unfamiliar?
Yeah, so redlining is a historical way of outlining where certain people should live and what access to certain resources is available in those areas. And we know that certain areas of the country have more access to healthcare, groceries, transportation, et cetera, and others don't. And so we can see the historical impacts of that through redlining. I don't know if you wanted to add.
Yeah, I mean, I think, the study design here was using something called geocoding, which meant that we took the individual's zip code and the area in which they live, on average, was linked to a social, sort of a social deprivation score. So we used an index score, which comprises a number of the things that Neha already highlighted: income, transportation, housing, food security, et cetera, and then provides an overall score that's called a social deprivation score. And 100 is the worst and 0 is the least. I got that in the right direction. Yeah. And then we also tied those zip codes to the average income for people who live in that area. So it's not, as you know, obviously people who live within the same zip code, there can be quite a bit of heterogeneity, but this is just on average. And it's a common way and a common method by which social determinants of health have been linked to certain outcomes in other cardiovascular or other even non-cardiovascular disease. So that's the methodology that we employed in this particular study.
And you followed this through the SHARE registry for almost 10 years, from 2015 to 2024.
Mm-hmm.
So this is deep data. This is really ripe. It's not the last 6 months of patients. It's a real understanding of where these people live, work, and have access to healthcare. So what did we find in the HCM community? What is important to know about the impact of social determinants of health to the HCM population?
Yeah, so we looked at 3 different outcomes. The first being a heart failure outcome. So are patients more likely to require a transplant, all of that, et cetera. We looked at a ventricular arrhythmia outcome. Are they having ventricular arrhythmias? Are they needing an ICD? Is an ICD appropriately shocking? And an overall composite, which takes the first 2 and also looks at mortality. And we saw that across all of the outcomes, for patients who had a higher social deprivation index, meaning more deprived or a lower income, outcomes were worse for these patients. So patients living in zip codes with a higher SDI and a lower income are more likely to have worse outcomes in HCM.
And it was most pronounced for heart failure, I would say. And that composite of heart failure, also includes people developing a worse symptom burden. So more advanced symptoms and as Neha said, transplant or progression to needing advanced therapy.
I find that highly in line with what I see, but a little depressing as well.
Yeah.
There's such an opportunity to get to people in time that they don't go into advanced disease. Yeah. Sometimes we can't change biology, we know that, but not even giving us the opportunity to get there in time seems to be what the issue really is here. We know where they are, but they're not engaging at the same level and they don't have the same access to resources as some of their peers do.
Yeah, so, just the other thing I'll add is that, that Neha adjusted for this is a statistical method, this adjustment where you can say well, if you even account for these other factors, because someone might say, well, it's because they had more hypertension or they were more overweight but those things were all adjusted for. And so the fact that they had a lower income or were more socially deprived, on top of all of the other things that we know drive heart failure and other adverse outcomes in HCM, made it even more striking, I think. And the other thing was that we found that, at least for the heart failure, I think it was composite, that the effects were even more pronounced in people that had sarcomere variants. So these were people that had familial disease. We can't completely explain that, but it was a bit surprising, because you sort of think of these individuals as, like their disease course is being driven by their underlying genetics, right? But, we're realizing more and more what other factors that are non-genetic contribute. And I think this is a really important one, and one that we can address as a society, so, from that standpoint, I think these findings were very impactful.
So Neha, you want to just, I don't know if you have the actual article there. I have it in front of me. Do you want to go over like the numbers that we were dealing with here? So there's 4,400 patients that were evaluated in this study. We have the average age looking, between 38 and 61, which is sweet spot for HCM, which is when you should be well, right? You should have your best health in those years. And then we've got 42% were female. So we've got a good male to female ratio here. The household income, which was about $80,000 between 60 and 110, was considered median. And 25, what am I doing here? And median SDI was 25. So you want to talk about what kind of household incomes were the most impacted and what your observations are of that data?
You can just talk about the tertiles, that you analyzed by tertiles. Yeah.
So thank you for having those numbers ready. I don't have the paper in front of me.
Okay.
But I think it's really important to note that median household income of our patient population is quite high compared to the national average. And why I say that is because the patients who are getting access to care to even be put in a registry like this, to go through the genetic testing and the echo testing, everything that they've gotten done, they're typically better off than the average person in the US.
And particularly in the areas in which the centers who were included in the study reside, right? And I think that was something highlighted in the paper, was the discrepancy in household income and social deprivation index, and that those that are getting the centers are better off than a lot of the people in the surrounding areas. So you can only imagine, the people that aren't getting to our centers, and, what.
So let's just take a step back for listeners. So the share centers that participated here, and I don't have their names here, but I know the institutions kind of by the top of my head. So we have University of Pennsylvania, University of Michigan, Stanford, Brigham and Women's. I'm going to guess we didn't use any of the information from Europe or Australia.
No, just because we couldn't.
Right. You couldn't homogenize that. And
Yale.
Yale was on here too. So these are large institutions in well-defined areas. There's not a rural population really to speak of here. This is more of an urban environment that these centers are located in, but patients travel in from a great distance in some cases. So it's telling me that if you're in one of those areas that is flagging on your zip code map, your geo map, and they're able to get to a center, they're probably better off than their peers. And if we were going to go down to the community level and work on community clinics, we would see something a little different than this.
Yeah, absolutely. I would think it would be accentuated. That would be my guess, right? It's that and because the people that aren't even getting to the centers are probably not getting optimal care in every case, right? Or at least our care that centers can provide. So I would expect that they would be even worse off potentially.
And the way we looked at the patient population in this study was we divided them roughly into tertiles, so into thirds based on either their income or on their social deprivation index score. And you can see that in the graphs that we have in the actual paper, there are 3 lines that represent the highest income groups, middle income groups, and lowest income groups. And then similarly for the SDIs, highest, lowest, and middle. And there's big differences between the highest income groups and the lowest income groups when you look at overall outcomes. And it's striking to see how just the amount of money that you live near makes such a big difference in your outcomes.
I am going to do the little thingy and I'm going to grab a screen here. Because I thought you're talking about graphs. We should bring up some graphs and show people some graphs.
Yeah.
Okay, so I'm learning how to do this one. This is a different format for me. I got to be ready for all of these inevitables. Okay, so the heart failure composite score, let's take a look at that and the arrhythmia and then the overall. So what am I seeing here, docs?
Yeah, so this is looking at income and all of the 3 outcomes that I had discussed before. So the top left is our heart failure composite, and the black line represents the lowest income groups. The yellow line is the middle group, and then the blue line is the highest income group. So if you're higher up on that graph, that means that your outcomes are worse. You have a higher incidence of heart failure. And you can see clearly that black line is much higher up than the yellow and the blue line, showing that patients who come from a lower income area have worse heart failure outcomes than the yellow and the blue lines. And similarly, the top right is looking at ventricular arrhythmias. This is a little tighter just because ventricular arrhythmias are not as frequent in this population compared to heart failure. It's a similar pattern again, where you see the lower income groups are higher up compared to the higher income groups.
I'm going to remove this and I'm going to bring it back because I made it look bigger. And oh, maybe it didn't look so much bigger. Okay, I thought it was going to be.
It's hard to see because the scale is the same, even though as Neha was explaining,
Yeah.
Ventricular arrhythmia is a less common or less prevalent outcome.
So what do we have to say about overall composite? That's a pretty steep arch.
Yeah. That does include some other things besides heart failure and ventricular arrhythmias. It also includes atrial fibrillation, which is something we looked at separately and had similar observations, that there was a higher incidence of atrial fibrillation in people who were more socially deprived or had lower incomes. It includes stroke and includes mortality. So that's why you can see that, it's that the total percentage of individuals who experience an overall composite, one of the elements of the overall composite is much higher than the other 2, because it's not simply an addition of the 2. There are other components to that.
So what are we learning about what some of these other factors are? What do we think? What do we know?
Yeah, I mean, I think there's a lot of work that needs to be done in this space to, 1, identify what exactly are the factors that are resulting in this, and then 2, what can we do about it? Right, like we know that all of these affect patients' health, but what can we do as clinicians, as other members of the team, the healthcare team, to ensure that we can improve care? So we see in our study that patients who come from lower socially resourced areas, they tend to present later in life and they tend to present sicker. So we need to find ways to have better pipelines for these patients to be seen earlier, for more preventative care, more access to primary care in these neighborhoods, perhaps more than in other places. We need to make sure that when we see patients that we're assessing for their ability to get care, do they have transportation to get to these appointments? Are they able to take time off of work to be able to get an echo, to get other testing that needs to be done, to see other subspecialists?
Can they afford their medications? you know,
Exactly.
right.
Can they afford their medications? Can they afford the copays and deductibles to go to the doctor?
Yep.
Are
Do
they on ACA subsidies that have now been cut? And are we going to see a reduction in their access to care? Are they Medicare, Medicaid, which may also see some reduced access issues? And thereby we can make those who are already sitting on a perilous cliff less supported financially. So I've got some real concerns over where we're going with healthcare, as has not been a surprise by my newest podcast, Tales from the Heart, Deconstructing Healthcare. Join us for the next edition coming up in a few weeks to try to figure out what we're doing right in healthcare in general and what needs to seriously get looked at.
Yeah.
But this economic playing field is such a major factor in outcomes. You know, we've responded to some of the things that you are documenting in this article, which is, I really appreciate this article. We've provided travel stipends now for people who can't afford to get to a center of excellence for their care. If they are below the poverty line, that we will help them get there.
Mhm.
We can only do so much on the financial side, but we can help people appeal with their insurance company and make sure that they get what is coming to them and what they need to have. We all need to raise our voices on the national stage when it comes to what are we going to do about healthcare and how do we make sure everybody has access. If we're seeing that low income areas have worse outcomes, that also means to me on the other side of this, there's probably a higher healthcare spend that could have been mitigated by some earlier actions.
Mhm.
So it's not just the, well, we should just give it to everybody kind of concept. We need to make sure the right resources are available for the right people at the right time. Isn't that what we're supposed to be doing? Doing real personalized medicine to bring customized care to patients, and that includes their socioeconomic status. So, what else do we need to know about these people and this problem before we can craft an action plan? Or do we know enough and we should just craft an action plan?
I think we should definitely start. Assessing for these factors in clinic is important. Even just asking, can you exercise? Are you in a safe place to be able to walk to get exercise? Are you able to afford your medications? If not, can we craft a different care plan for you that accounts for that? I think these are all steps that we can be actively taking right now as a healthcare system. It does not necessarily always happen in a busy schedule. I think moving forward, using different risk stratification models like the PREVENT score that we have for more acquired cardiovascular diseases, to be using that as to assess whether patients should be getting different treatments sooner would be really important. Essentially, just including this in their healthcare and how we think about them moving forward.
So I'm going to go someplace that's probably going to get me in trouble at some point, but it's okay. If we're acknowledging that there are socioeconomic differences in outcome, and we know that the money is going to be spent when quality of life is diminished, and we can go back to the other side of the equation and we can get in there sooner with better ways of mitigating risk. I'm going to give a shameless plug to one of our programs here at the HCMA called the All Hearts Collaborative, in which we are seeking to get into urban areas and cities with an app to help families identify their own family heart health history risks and get into care sooner. So, like, obviously, as I'm like looking at the programming that we're developing here at HCMA, and I see this article, and I'm like, this is validation of all hearts. This is exactly why we're doing it, why we're bringing it to the community. And we don't know how successful we're going to end up being in this endeavor. We hope incredibly so. But we are going into our pilot city, which is Newark, New Jersey. We are educating community health workers. I've gone already into 2 federally funded health centers. We've got more coming up in a couple weeks where we're going in and training them how to identify the families who are at risk, and then helping pipeline those patients to high-level care models that they probably wouldn't have had access to without this outreach effort. But we can do more to treat more people.
It's amazing what you're doing, Lisa. I just want to say, thank you for all of your efforts, but we need to get into the community. We need to, not have people coming to us, but we need to go to them.
Right.
And we have to find more creative ways to do that. We love to, to be someplace where we have all the resources and we can do all these fancy tests and everything, but at the same time, there are some basic things that we could provide in a community. And, Penn is doing this through, an expansion program where we're also, this is a Penn medicine wide thing, but we're expanding into other areas in New Jersey and throughout Pennsylvania and so forth, Delaware, to
We're
try.
going to bring the Jersey girl back to Jersey at some point. I'm sure of it.
Yes,
We'll drag you back.
I grew up in I grew up in New Jersey through high school at least. So yes, so Lisa still calls me a Jersey girl.
Girl, you go to high school in Jersey, you're a Jersey girl. That's just the
I
way
had
that it's
Jersey hair to prove it, but I won't show anybody the picture. Yeah, but I mean, the idea is like we need to expand. I mean, this is something that's happening, at our institution as a whole. But I think as an HCM community, we really need to think about creative ways to get into the community and not just sit in, our ivory towers and wait for people to get to us when they don't have the capability to do that.
What if you're one of these families right now? What if you have HCM and you're not high income? You're at that $60,000, $80,000 range and you're like, okay, when you look at national standards, you're doing pretty good in comparison. But when you're looking at healthcare and you're looking at a program like this article, you see that you may be disadvantaged.
Mm-hmm.
Any tips or hints on what people can do to optimize their care, even if the social determinants of health are not in their favor? How do we turn it around for them?
I mean, I think self-advocacy is so critical, right? And I think, you have a lot of these families as part of your community in the HCMA, and, trying to get them access to expert care. While we are trying to, again, expand expertise into their community, right? I think that's the key, is that there still isn't a lot of expertise and literacy even around HCM and genetics beyond these expert centers or centers of excellence, right? And so, while we're trying to do that, at least trying to funnel the patients into the centers of excellence where they can at least get, at least have a single consultation if they're, for their insurance. And most insurance do cover the visits. And if they have a viable means of transportation to get to us, or if they can get a travel grant through the HCMA, I think to just get at least a consultation to make sure they're on the right track. And if they're not on the right track, then help them to get there. But earlier is better. And the earlier they get to us, the better, because it's, as at some point there, we have limited treatment options once the disease is, far along.
I'm thinking back to some of the clients that I've had over the years who really struggled, and they were in particular communities where access was difficult, where walking streets were not safe, where the groceries were not really fresh and you're getting mostly packaged things. So if I look at this at a very high level, some of the things that we try to identify within a client during their intake and navigation call are some of these social determinants of health. And then looking for, is there, and I know there's not many of these anymore, but we used to default to the mall. Can you walk in a mall? Don't bring your wallet, just go walk in a mall. And there's not a lot of malls anymore.
Yeah.
So like my 80s girl is like really looking for her Orange Julius at the Rockaway Mall, but it's not there. So indoor walking opportunities where you're safe, to evaluate those. Some people go into big box stores and just wander the halls if that's what they have available to them, but that's an option, especially in cold winters or hot summers. You get your temperature control. Trying to get in as many fresh fruits and vegetables into your diet as you possibly can will maybe help mitigate some of the food desert things that we run into. And looking for additional resources, whether it be from social services or friends or community members, houses of worship, et cetera, to get rides back and forth to centers. So looking at the things that you can change or mitigate to some degree could actually change the fact of you going into heart failure younger. I really worry about the women in these communities. Even though your data was 42% women, it was just representative of what was in the registry. But women are less likely to prioritize their own health because they're prioritizing the health of others. You guys want to talk a little bit about what the girls and the women out there should be doing to advocate for themselves?
Yeah, I think it's a lot of what you said earlier too about like education around the topic. Um, you know, what happens, like you mentioned, that women tend to think about other people's health, their family members. It's usually the wife that's bringing the husband in because of whatever symptom they're facing, but then they forget about their own. And so educating them on that is really important, getting the word out within the community that it is important to get preventative health care, that it's important to listen to your body, not ignore those signs, which often does happen. And the more word that we can get out, the more helpful it is for everyone.
Make sure they're not being dismissed by their physicians, right? By their healthcare providers, which also happens, right? So that, a lot of the disparities and, sex disparities and, a wide variety of studies, HCM included, is, for HCM specifically, women have a higher mortality overall, and they present later, and they're often in more advanced heart failure when they present, right? So we got to get them in earlier.
So this goes back to the core mission of all hearts, knowing your family heart health history and when to take action. If you're in an HCM family, you're kind of ahead of the ball here because we know you're at risk, your family's at risk, we can screen you. It's your neighbor that doesn't know that's worrisome. So we need to be comfortable, and we're doing this talk right on the precipice of Heart Month, where everybody's going to get sick of hearing from me all month long on all different content. But this is our opportunity. This is the time of year where we can talk about our hearts and say, well, it's Heart Month. I have this information to share with you. Behind me on the wall, you're going to see what you guys are going to be getting in the mail in your office shortly. We have a number of boxes that are going to be going out to all of our centers of excellence so they can celebrate HCM Awareness Day, which is February 25th. It's the last Wednesday of February every year. So we'll be able to talk about it at the clinic and with your peers and do in-services around this. But we have, just for this year, next year I'll have more of them. We'll have house party boxes, which have the same materials, and some of our new like wristbands and all the fun stuff, and a couple of other things. Like there's other things. There's other things in the box. You'll see them later. But you can have the opportunity to talk to your house of worship, to your girls club, to your reading club, to the sports team from your community, to your PTA, anybody that will listen. I have been in front of a few audiences in my life talking about HCM. And it never fails that as you're explaining the signs and symptoms, shortness of breath with or without exercise, the feeling like your heart is racing out of nowhere, your head is spinning, chest pains, passing out, nearly passing out, and maybe you have an innocent heart murmur. And when you start to pull all of those together, you see people in the audience tipping their head and looking at you with a little bit more fear in their eyes. And they come up and say, well, my grandfather had this, or my father had that, or my sister did this, or I feel that. It's like, you need to meet a cardiologist, not me. I can just tell you need to meet a cardiologist. Please go meet a cardiologist. So knowing who those people are, February is your chance to talk and help find them. We know that a lot of people have HCM, and there are people in my own life who didn't know they had HCM that come around having HCM. I'm like, I don't know if I maybe cause it in some people. I don't think that's been proven yet. But people I've known 30, 40 years are like, Lisa, I just got diagnosed with HCM. I'm like, welcome to the club. And they're like, oh, now I understand what you do. So it's out there. 1 in 250 to 1 in 500 have it. We got to find it and get them into treatment sooner. And if you have socioeconomic challenges, if meeting your bills are not working to get your meds, call us and talk to us. I can't solve everybody's problems, but we might have resources and pathways and programs that you might not be aware of that you might be eligible for. So don't be afraid to ask. Okay, Neha, I'm going to give you the last word on this. The conclusion and the relevance of your study. What do you think the most important things are?
To be aware that there is more to your health besides the numbers that we typically see on our computers. It's not just the lab work, it's not just the blood pressure, it's where you live and the access to resources that you have. And it's so important to recognize and talk about it in clinic. As much education that can go out is so important, and advocating for all of our patients is extremely important. I hope that moving forward that we are more aware and more and are doing a better job at that for everyone.
Well, I am very happy to see that the next generation coming up is starting focusing on the social determinants of health. Yes, the clinical parameters and the clinical management is critically important. However, if we're starting with an uneven playing field, the outcomes are always going to be worse for those who have less. So how do we balance the playing field going forward? I don't have all the answers today, but I do hope to continue the conversation with the both of you and others over the coming years, as I do believe it is our time to make our mark in healthcare in 2026 and beyond. Things are going to change. Technology is going to come, and it could be that some of these new technological advances could level the playing field a little bit by giving access through virtual medicine, through telemed, through wearable devices. We don't necessarily have to go build more brick and mortar. We have to think a little bit harder. And if we think a little bit harder and get a little bit smarter, I think we can provide better care and balance that playing field.
You're absolutely right. Those are really critical elements to us getting into the community and not waiting for people to come to us. And obviously just addressing healthcare as a society and as a nation. Paramount importance.
So there's so much I can say about that last part right now, and I'm going to uncharacteristically edit myself quite a bit here and say, I don't know where you're listening to us from. I don't know what your political leanings are, and that doesn't matter. What matters is we are all humans. We all have hearts. They are all not perfect. And even if you have a good heart, at some point in your life, you will become the thing you never thought you would be, and that is a patient. And when it happens to you, we need to have a strong healthcare system ready to address whatever your needs are, no matter who you are. And we need to make sure everybody has that access. So, I'm 9 years almost into Brandy here, and her and I have been doing a lot of great work, but the rest of the time I have here will be spent on equalizing the playing field and ensuring that everybody has access to care, because nobody should die for lack of access or die too soon for lack of access. So I will leave my political statements there.
Well, Lisa, we just want to thank you for everything that you do at the HCMA and for the entire HCM community. And of course, today, thank you for highlighting our study, and we hope it makes a difference.
I know that it will, because people have already listened and more will. So thank you, ladies, for joining us today. Charlene, thank you for being a great mentor to Neha. Neha, stay on the HCM path. We're a good career choice. And then I get to keep working with you. All right, ladies, thank you so much. And we got a thank you from Chris. And we had a comment from Laura earlier. Laura, I don't know if you hung out with us or not. It was good to hear from you. Oh, there she is. Demi's trying to share it. I'm trying to save it and share it. So yes, Laura, I agree. This is a critically important time. And I like your dog picture. That's not your dog though. Okay, ladies, thank you for joining us. Everybody, thanks for listening. We did have one little technical issue with the Facebook page. So this is going to get posted from my page to the Facebook page. For those who didn't catch it live, my apologies. Thank you, guys.
Thank you so much.